Welcome, everybody. Rush University Medical Center Division of Nephrology Renal Biopsy Conference for February 8th, 2024. We do have a CME code today, 490489. Welcome, everybody. It's nice to be back. We've got a fun case today. As I put in our tweet, it spans several years, and it's not only the medical aspects of spanning several years, but the technology and other things that span years. So hopefully make for a healthy, nice discussion. Dr. Glassick is not with us today. He's golfing. He turned 90 this week, and so he's out golfing. And I'm glad he's not here because I want to tell everybody next week we are going to surprise him with a happy birthday song. So we will at some point, I will say something. It'll be obvious. I will unmute everybody, and I want everybody to sing. It's just not karaoke. We'll all be blended together, but I think it'll be a lot of fun. He's such an amazing man, and to be as active as he is at 90 is absolutely incredible. So I want to wish him a happy birthday. It'll still be a week late, but I think it'll be a lot of fun. So be ready next week to we'll unmute everybody, and hopefully everybody can sing, and we'll sing together and not make too much of fools of ourselves, and hopefully embarrass him. But I think it'll be a lot of fun. So getting on with the conference today, we have nothing to disclose, and we protect the patient's privacy by changing anything that's important, identifying information. Dr. Dr. Baxi has the case. Pravir, you want to walk us through it? There's a timeline that's really important, and he'll remind you of the timeline, but it's really important that you realize the timeline as we go through it.
Absolutely. Yep. Here, I'm going to share before I start talking. I'm going to share the file so everyone has, for those who can't see the screen properly, share a PDF version of it. There we go in the chat. All right. So this is a 16-year-old, and this is at the time of the biopsy. And so, again, I'll go through the timeline. So it's a 16-year-old Hispanic male who presented to the nephrology office for a reevaluation. Now, he was initially seen by another pediatric nephrology office when he was originally 6 years of age. He was found to have hypertension, and routine screening with the UA showed that he had microscopic hematuria, and this was done by his primary pediatrician, and so he was referred to a nephrologist. Labs from that time, which we were able to obtain, showed his creatinine was 0.5. And they did quantify the protein, and there's no quantifiable protein, but his UA did have 30 RBCs and dipstick blood. There was no mention of any gross hematuria. He did have an elevated BMI, and his appetite was admittedly poor. There was no family history of kidney disease or autoimmune disease that was recorded. He was started on lisinopril and instructed on a healthy diet and encouraged weight loss. Unfortunately, which you'll see with this case, he did not follow up after with a pediatric nephrologist. And then he presented now at age 16, so 10 years later, again by his primary pediatric team for evaluation. So at this time, he's seen by his pediatric nephrologist, and his BMI is now 43.6. He still is completely asymptomatic, and exam was really unremarkable. His labs were drawn, and his creatinine was 1. And his albumin was normal at 3.4. His UA had dipstick protein with blood. He had greater than 200 RBCs. The protein quantification now showed a urine albumin to creatinine ratio of 3.9, along with a corresponding urine protein creatinine ratio of 4.9. His hemoglobin A1C was checked with 6.1%. He did admit to going to the gym regularly, but he was taking a lot of pre-workout supplements, energy drinks, but he adamantly denied any steroid use. Nothing to note on review systems, as I mentioned. In terms of birth weight, he was born at term. He had no other childhood illnesses. He did have asthma, which required albuterol as needed, but really did not have any severe asthma exacerbations. And of course, he had the hypertension and microscopic hematuria, which he was diagnosed previously. Social history, nothing remarkable. Family history, only of hypertension in the mother, otherwise completely negative. His exam, his blood pressure was 130/90. He was not taking anything at the time of this reevaluation. His BMI was up to 43. And he had no major things to note. He had no edema, no rashes, otherwise really well appearing, his age, and I should mention he was doing good at school, really nothing else that was going on elsewhere. In terms of his labs, sodium was 143, potassium 4.4. His chloride was 108, bicarb 28, BUN 15, creatinine 1, glucose was 90, his albumin was 3.4, his liver functional panel was normal, his cholesterol was, his lipid panel was checked, his cholesterol was 198, LDL 115 with triglycerides at 210, CBC, normal white count, hemoglobin was 12.2, normal platelet count with MCV of 79.6. Serological evaluation was done, and his ANA, ANCA, anti-double-strand DNA, and this includes MPO-PR3, were all negative/normal. His complements, these are normal within our laboratory range. His UA I've already mentioned, and then he did have a renal ultrasound done that, again, did not show anything of note. And so a CT-guided percutaneous biopsy was formed. Again, this is 3 years ago from present date, but this is these labs and everything are at the time of this reevaluation.
Great. Any questions for Pravir? Well, that's a first.
Crystal clear.
Yeah, it's so crystal clear. Exactly. We can just go directly to the discussion. Great. I think we're going to start with a poll. So, poll number one, what do you think this patient has? Do they have IgA nephropathy? Do you think they have a FSGS pattern of injury? A type 4 collagen related nephropathy, membranous nephropathy, or lupus nephritis? Take your time. We'll pull this up. No one can see your vote. I'll tell you right now, it's pretty well divided.
Pretty well divided.
Dr. Baxi put in the poll, he said FSGS pattern of injury would include ORG related, which I think is a good point.
And that, I mean,
It's always difficult now.
ORG.
Do we make these things separate on the list when they're kind of an overlap? So that's why we're moving more to these just pattern of injury statements that kind of blanket cover a few of these things. So if that's what you think, then you would pick number 2. Somebody asked about hearing problems. There was no hearing problems. He said there was no vision issues either. Good questions. All right, you want to show?
Yep.
Okay, we've got 38% said IgA nephropathy, 27% said FSGS pattern of injury, 32% said type 4 collagen nephropathy, and we have one membranous. And so I'm going to ask Dr. Whittier to tell us if you can keep the poll up and he can kind of address each of those individually, it'd be kind of nice. So Bill, what do you think's going on?
Yeah.
So before you go to Bill, what is the impact of having no visual or hearing problems?
I'm assuming that was alluding to like Alport's or hereditary nephritis. But, I think that's what someone was alluding to. Possibly.
Yeah, well, it's interesting. It so happened that today I stream a conference from Australia from an outstanding Alport's researcher, name of whom I forget because I'm old.
You're not that old.
Point is, I learned a lot of material, and among that, the fact that, for example, autosomal dominant Alport's is not customarily associated with auditory problems. The X-linked forms are. Some genetic forms of Alport, and there are at least 5 or 6 these days, may not have what we used to link to the hearing, the visual, and what have you. So the fact that a patient doesn't have it doesn't rule it out.
Absolutely. And, there are thousands of mutations that lead to these syndromes. It's not monogenic at all. And so the phenotypes can be extremely helpful. But I mean, the fact, if he had hearing loss or visual problems, that's relevant. So I think it's relevant that he doesn't. But your point is absolutely spot on, Mario.
Well, I think what Mario's saying is it's the alpha 5 chain that's in the ear and the eye, and the alpha 3 and alpha 4 don't include those. If he had alpha 5, then he wouldn't have normal renal function right now, that's for sure.
Right on.
Cool. Okay, so with that, Bill, you want to hopefully there's something left.
Yeah. No, I'm glad Steve said that because I really I can't it's hard for me to remember which chains have which one. So that was very helpful. Thank you. Maybe I'll remember that, but don't ask me next week when we're wishing Dr. Classic happy birthday because I don't want to be further embarrassed as I normally am.
Just say pattern of injury and you'll be okay.
Yeah, pattern of injury. And you had birth weight in there, Pravir, so Dr. Classic would be quite proud. That was really impressive. When this kid starts out with 6 years old with basically he has isolated microscopic hematuria, which is microscopic hematuria in the absence of proteinuria, he had normal renal function, no hypertension. 90% of those in adults when they come like that, and there's again no proteinuria, no hypertension, normal renal function, you have a urologic issue. And so about 80 to 90% of those are urologic issues. And so they should be referred to urology first for the cystoscopy and as well as imaging of the upper poles. I don't know if that's the case in a 6-year-old, but regardless, whether he had that or not, he starts to soon develop albuminuria, and therefore that takes it out of the isolated microscopic hematuria realm. And once you're in that realm where there now is albuminuria and someone who started out with the hematuria, the sort of the standard differential becomes some variant of Alport's or a non-albuminuric, or which is now then becoming albuminuric IgA nephropathy, or even what we used to call thin basement membrane disease, which again is likely isn't really a term that we shouldn't be using anymore, and it should be some sort of maybe milder variant of Alport's, as was just discussed. And so, how would I narrow those down? Well, it's difficult. You'd have to do the kidney biopsy, but he is Hispanic, and so you might think that IgA nephropathy may be a little bit more common there. It's also possible that he just really has some quote unquote thin basement membrane disease, which never really would have developed albuminuria, but his obesity has caused some sort of hyperfiltration injury on top of a thin basement membrane, and maybe that's enough to give the albuminuria. And so because of his clinical presentation, I think the differential is still pretty diverse, and I think a kidney biopsy is necessary. I really wasn't thinking of lupus or of membranous, which is 4 and 5 on the list there. But those are always possibilities in somebody who's got hematuria, albuminuria, and so on. But I was sort of limiting it to the differential that I discussed.
Great. Casey Gashty, what do you think this patient had? Did you put your nickel down, Bill?
Damn it.
I don't think so.
I said
You didn't. You know how this conference works.
I think I said it's really difficult to narrow down.
That we need a biopsy.
It used to be a quarter. It used to be a quarter.
Well, at least it's just a nickel. Thank you. So, yeah, I think I don't know. I kind of like the idea of obesity-related glomerulopathy on top of some sort of classic milder variant of Alport's. And the reason the proteinuria is there is the obesity. I just like that story. It clinically fits quite well with his presentation.
Casey?
So I agree with Bill's differential, which was basically the poll, but I think my order would be, because he's Hispanic and he started with hematuria and then the proteinuria got worse. I do like IgA. It's just a more common finding statistically in people. Being the most common GN. I'm making air quotes here in case nobody's seeing me on video. But since he started with hematuria and then the proteinuria seems like it came much later, I feel like a type 4 collagen issue would, by itself doesn't, 5 grams of proteinuria. I have a little bit of a hard time kind of putting those two together, and the secondary FSGS or pattern of injury to start with all that hematuria and then get proteinuria much later at the age of 6 years of age. I feel like I don't know if the data that we see in secondary FSGS related to obesity, for example, if is reported in that pediatric population of that age, like 5 or 6 years old, started to have issues with that much blood. So if we see like an FSGS pattern of injury, I don't think that's going to be the sole finding. I think that's going to be confounded on top of some underlying other thing like an Alport or a collagen disease. But I think IgA is the one diagnosis that explains both the hematuria and the proteinuria. And, you know, obviously the patient being Hispanic, it's more common. So I'm going to put my nickel on IgA.
Oh, this is a throwdown.
I'm gonna keep moving around. Dr. Reen, you can't just say what you think. You gotta give it you gotta give your explanation.
Okay, I actually think it is IgA nephritis. Exactly the way Dr. Gashti told. Those are my explanation. It could be FSGS. I wouldn't rule on thin basement membrane disease because of that can be possible, autosomal dominant collagen 4 disorder. But my money is on IgA nephritis, exactly the reason what Dr. Gashti told.
Dr. Rubin, you have collagen on the mind. What do you think's the diagnosis?
I think it's FSGS, a secondary form. But certainly IgA is possible. So we'll see what the biopsy shows.
Do you think it's a secondary form like a genetic FSGS, or think it's ORG, obesity related?
Either.
Either. Okay.
I will keep APOL1 in this case also if you're thinking FSGS, because Hispanics do have 10 to 15% of FGS, and I will keep that in mind.
How they have 10% APOL1? I mean, it can't be.
Yes.
Oh, that's
Yes.
much higher than I thought. Okay, interesting. Anybody else want to throw anything in? And we've got some stuff in the chat here. 30% of IgA Chinese have COL43A genetic mutations. Interesting. Okay, I think that it's time to spin the wheel.
Can I put my 2 cents in?
I said, and you didn't speak up, so.
Well,
Wait, we all had a
you're-
nickel and you're just putting in 2 cents? That's
that's-
not right.
It's
That's
about
Not
yeah.
right at all.
And he wanted to make it a quarter, cheapo.
I mean, yeah, when it comes down to it.
Inflation.
I'm gonna tie it all together. IgA nephropathy patients can have thin basement membrane nephropathy, and that can be seen in 20-30% of cases of IgA. IgA can also have segmental sclerosis, which we talked about, I think, a few weeks ago, and Gary Hill described that whole, the fact that IgA patients, you can apply the Vivette-Degati classification to patients with IgA that have these segmental lesions. So I have a feeling this person is going to have IgA with thin basement membrane, and there's going to be segmental sclerosis with a podocytopathy.
Why do you want to give both? Why do you need to give both? If IgA can explain, hematuria and proteinuria, why do you need to
Because
have?
greater than 300 red cells is a lot more than I would expect for just basically IgA, unless they're having gross hematuria.
Got it. Got it.
I
All
think
right.
the food processes are going to be preserved, and if it is FSGS, it'll be a secondary one.
So we've got a podocytopathy and no podocytopathy. We should really, I think we need to start actually betting on this. We've had from 2 cents to a nickel to a quarter. I think it should be at least $1.
Well,
Well, maybe we can put Zell on this thing so we can, pass it along.
I'm sure there's an app for it.
I'm sure there is.
It's like if you guys remember the movie Trading Places.
Yeah.
These billionaires, they bet $1 just for the for the sake of the bet, not for the sake of the money. So for the sake of the pride, anyway.
And ruined Dan Aykroyd's life.
Great movie if you haven't seen it. This is a full service biopsy coverage, by the way. We cover everything. And the wheel picks Michael. Michael Coleman is one of our first year fellows.
Give me a second, Michael. I'm going to unmute you. Great. Try to go ahead and test out your audio.
Can you hear me?
Yep, loud and clear. I'm going to give you control. Give me a second. All right, click on the screen. Yep, and remember there's sometimes a lag, so you can advance the slides at the bottom left. Do you see it? Yep. go ahead. Yep.
Okay, so this is a trichrome stain of 1 core. You can see blue glomeruli here. And I would say amount of fibrosis maybe about like 20 to 30% or so.
Yeah, Michael, that's what I estimated.
Thanks.
Okay. Yeah, so there's some chronicity here.
Okay, next slide.
Which is interesting because his creatinine was 1, right? On presentation, which is
Yeah.
pretty normal for his weight and
Yeah, 1 may not be so normal for a 16-year-old though. I don't know.
maybe not. Yeah.
So this is an H&E stain. And
PAS.
oh, this is PAS. Okay. PAS stain. You can see glomerulus here, here, here. I don't see any, like, this is a low power field. I don't see many abnormalities though in the glomeruli from this viewpoint. Some maybe like lymphocytic infiltration here and here.
Yeah, so Michael, there's already global glomerular obsolescence. You know, those round balls of collagen are globally sclerosed glomeruli. Yeah, just above the pointer a little bit. If you move it right there, yeah, that's a sclerosed glomerulus.
Okay.
And then up to the top left, there's 2 more. Yep, that's another one. And then it's another one. Yeah.
Oops. Okay, so this is also PAS stain. Here's the glomerulus. The capillary loops look pretty open here, but here, this might be a little bit of a sclerotic lesion. Not
Right. What would we call that?
like a focal lesion.
Segmental scar. Yeah, segmental scar. Yeah.
Okay.
Yeah.
Yeah,
Yeah, you could point out the adhesion to Bowman's capsule there at like 2 o'clock.
oh yeah.
Yeah.
You know, Michael, it's good job, but sometimes it's not that easy to pick the. I mean, there's a lot of better segmental scars than this. One of the clues that you just pointed out is that when you see that adhesion, it really, to me, it's always the the icing on the cake, which makes it a lot easier. But it's not. They're not. This is not the easiest scar to see. But good job.
Thanks. And the tubules surrounding, I don't see too much here, like maybe some lymphocytic infiltration, but I don't see ATN. Yeah, everything else looks okay to me.
Okay.
This is H&E stain.
PAS again. See, it's kind of magenta.
Oh man, okay.
You know what, Michael? One thing I learned: if you keep saying it long enough, you'll eventually be right.
Oh yeah. Okay, so this is the glomerulus. Here the capillary loops all look very open. I don't see any hypercellularity between the capillaries. I don't see any mesangial proliferation between the capillary loops. So it looks like a pretty normal glomerulus to me.
Yeah, right.
Just wanted to highlight that there was no mesangial hypercellularity. Is that what I heard you say?
Yes.
I'm getting my nickel, I think.
Okay, so this is the silver stain. And this looks pretty good to me too. I don't see any spikes or holes in the glomerular basement membranes. The capillary loops look open to me.
Yep, yeah, I agree. It looks like a normal silver stain.
Okay, and then this is PAS.
Oh no!
Oh no! Of course that happens. Okay, so this is H&E. And I mean, this is looks like a lot of lymphocytes here. I don't see any glomeruli.
Yeah. Where's that infiltrate?
In the interstitial space.
Interstitium, yeah. And then do you see any other type of cell there mixed in?
Oh, is this an eosinophil?
Yeah. Actually, that's probably maybe a red cell, but just above it, there's 2. Yeah, there. Yeah. So there's some eosinophils also.
Is that an eosinophil?
Yeah. I mean, they have granular cytoplasm. So that one there on the far right, I think is like a unlicensed red cell, probably.
Okay.
Yeah.
And then these are just tubules, but I don't think
Yeah.
it's or anything that
Yeah.
really indicates ATM. Maybe like a little here, but
Yeah. So he also had this interstitial nephritis with eosinophils. That was focal.
gotcha.
And there's a little bit more of it.
Yeah, a lot of lymphocytes
Yeah.
here. Okay. Is this a red blood cell cast or
I think those are red cells in a peritubular capillary.
got it?
Yeah.
Okay. And this immunofluorescence, which is clearly negative.
Yeah, IgA, G, everything was negative. Okay. And then, yeah, there was no glomeruli for the EM sample.
Oh, all right.
That's all. That's yeah. What's your diagnosis?
Okay. For the most part, there was one glomeruli that had a segmental lesion in it, and then we saw AIN as well. I didn't see any ATN. And there were no like fibrinoid necrosis or anything like that. So yeah, I would just probably say FSGS with acute interstitial nephritis.
Good. Excellent.
Next slide.
Normally also, David, obviously, if there is a segmental sclerosis and we're worried about ORG, we would think that there'd be glomerulomegaly too. And I don't remember if that was commented on. Did you comment?
No, they were normal size. There was no enlargement.
Right.
Yeah.
So we'll never know if they were stem basement memories, obviously.
Yeah. Right.
Yeah, that's
Unless we do some genetic studies or something.
that's a senior nephrologist picking up on that for us. We appreciate
Yeah,
that.
well, I thought it'd be, complete.
So, Bill, I'm going to hand it back to you.
Well, I
What,
think
what do we know? What we don't know? What can we rule out? What can we rule out?
Well, yeah, we ruled out IgA nephropathy. Okay, so that's essentially about it. I mean, this could be a hereditary type of focal sclerosis. It could still be a hereditary type of Alport's. We don't. I guess actually we could have done Sorry, did we do the collagen change on the immunofluorescence?
No, nobody asked me to perform them.
No.
Okay.
No.
All right, I'd like to see those then. I'll ask right now. No, I mean, that would be something that I think that we could start with, and then, I think genetic testing can help kind of, narrow this down as well. Do we need to do a repeat biopsy to see if we can get EM? I think I'd probably wait on genetic testing before I got to that level, and I'm not quite sure I would need to get to that level because it seems that I don't know if we're ready to talk about treatment yet, but I'm not sure repeat biopsy for this particular patient. It may be for his future or for his offspring, but for this particular patient, I don't think we would find something treatable that is different on the repeat biopsy. So I think just starting off with genetic testing and some empiric therapy would be what I would do.
What about, do you feel like ORG is ruled out?
Yeah, I have to. I mean, obviously, we're used to glomerulomegaly along with a possible focal scar, and we did not see glomerulomegaly. I had to go back in the studies and see if there was a certain percentage of patients with obesity-related glomerulopathy that did not have glomerulomegaly, and I don't know that. I mean, maybe if 10% don't have it, is that possible that this is one of those?
They all had glomerulomegaly in Bavette's paper.
Okay, but
In
that
fact,
might have
some
been,
of them had glomerulomegaly and no FSGS. That was
yeah.
Yeah,
So,
I mean, I don't think was there anybody in their teens, Steve? Do you remember?
Pardon?
Was anybody in their teens?
and I think their age average was 40, but I'd have to go back and look and see how young they were. I mean, I agree with Casey's point that, this is something you usually have for a long time, but I don't remember what the youngest patient was, but I do know, just to Bill's point, at least in that paper, I don't know of other papers that have looked at this particular entity to see, but they found a glomerulomegaly in everybody that they looked at least.
And
And
not
most of them
necessarily
had
stars.
FSGS, but not all of them.
And I don't think ORG alone or focal sclerosis alone would really explain this degree of hematuria. Obviously, you can have hematuria with focal sclerosis, but this seems pretty significant and even started off with hematuria before the proteinuria. So I'm still suspicious that there is some sort of basement membrane abnormality that's just not IgA. I think it'll be, I think there's still going to be some sort of Alport's type of variant here, and that's why I think maybe genetic testing would be helpful.
Bill, mainly for the fellows, can you please comment on the impact of the lack of electron microscopy in the ability that we have to differentiate primary versus secondary FSGS, and also on the lack of edema and the normalish albumin?
Yeah, and that's kind of why I was thinking in the beginning that there would be preserved podocytes, because the clinical situation that you have with secondary FSGS is not one of nephrotic syndrome, but it might be nephrotic range proteinuria without edema. And then the biopsy with a secondary forms of focal sclerosis typically does not have diffuse foot process effacement. So those two go hand in hand. And then the primary FSGS, which is really a diffuse podocytopathy, that's the one that also clinically presents with nephrotic syndrome, similar to the way that a minimal change might present. And that's the one that you really want to target with steroids versus the secondary or the genetic ones where you, or even the undetermined possibly, you wouldn't use immunosuppression.
Steve, how do you feel about, one of these congenital Potosin type of abnormalities for this case? You have to unmute yourself.
Yeah, I mean, usually the kids that have hereditary forms of FSGS, and in this case, it's obviously there's no family history of it, if I recall right, Pravir?
No family history.
Yeah, so then you're talking spontaneous mutations. Those are usually steroid-resistant nephrotic syndromes, and they can, and in children, up to 30% of them or so can have spontaneous mutations. So that's why actually you do genetic testing in kids that have steroid-resistant FSGS, because they can be they can have spontaneous mutations in Potosin in particular.
So I'm not approaching it that way because we don't know anything about treatment or whatever. What we know is that he's 16 and has, and he has a single segmental scar, and he's got 4.9 grams of proteinuria and a normal albumin and a mildly high blood pressure. Do you think that is possible that it would fit a spontaneous mutation?
Yeah, I mean, yeah, it's possible.
I'm sorry.
It's possible. I mean, the other thing I was going to say is, or ask is, again, remind me, Pravir, did he have edema?
No edema.
Yeah, I mean, here's a guy, he's got no edema, he's got essentially a normal albumin, he's got nephrotic range proteinuria. The answer to your question, just simply put, is yes, it's possible.
Good.
Anyone on the AIN? Did anyone? Sorry, there was.
How much EIN was there? It was just a little patch.
I was taking supplements, so.
As an aside, I just put this in the chat. I looked at Vivette's paper. The age went from 8 to 71. Now, 8 seems a little on the young side. But they didn't tell you what, the mean age or the median age, I think, was 40 something. So 42. But they did have an 8-year-old.
Interesting. Yeah, that's, I mean, it's a kind of a diagnosis exclusion, I think, but, Vivek Dagati's a pretty good real pathologist, so we're going to accept that. I'm going to accept that. So that is interesting. That's a good point. I'm glad you pulled that up. Want to hand it back to Pravir?
Yeah. So this was 3 years ago. So a lot of the genetic testing, I mean, it is much more readily available now than it was even 3-4 years ago. So, I think those are great points. So coming to now, present day, now that's the time of the biopsy. 3 years later, he presents to me. And before I move on, actually, I forgot, he was treated. So what happened after this? So as many people mentioned, he's treated for FSGS, lisinopril. He was given a course of steroids for this patchy acute interstitial nephritis. Unfortunately, which was, again, the case with him from the beginning, he really did not follow up. He, was weaned off his steroids, up titrated, but then lost a follow-up. He continued to have a high protein diet. He stopped all his supplements. And over the course of the next 2 years, he is followed by primarily his pediatrician and not the nephrologist. And his creatinine trended up to about 1.4 to 1.6. His urine protein creatinine ratio came down to 3 grams, and his albumin remained normal with a level of 3.5. And now he comes to me. This is about yeah, go ahead.
Real quick, if we could just make a point, go back.
Yeah.
Depending on how far along away this was, but presently, I don't think anyone would be treating this person with steroids if they came to you now. It just really fits a type of a secondary or undetermined type of FSGS.
Mhm.
We don't know the foot processes like we just talked about, but I think somebody like this is more of not a primary FSGS.
No, but he said they were using it for interstitial.
I think it was primarily for AIN.
Oh, gotcha.
Yeah,
Okay.
yeah.
And again, I'm not sure I would have done that either, but I can see if it was diffuse AIN that I would consider that.
I wouldn't be so sure that it was just for AIN. I think Bill's point is very valid.
Mhm. So he comes to me now. Again, this is 3 years after the biopsy. He's 19, has not seen his pediatric nephrologist for about 2 years, and he's transitioned to adult nephrology now. He's not taking lisinopril. He's still taking multiple vitamin supplements, but no herbal supplements. He's going to the gym regularly, has a high protein diet. He's lost some weight. His BMI is down to 35, but still obese. His blood pressure is 130/70 without any supplements, and he still is feeling great. No symptoms, no edema, no rashes, doing well in school. So I get labs. His creatinine is now 3.2. His albumin is 3.8. His hemoglobin is 11.4. His urine still continues to have blood, although a lot less RBCs. And his UAC and UPC are about the same that they were about 2 years ago. But he has much significant decline in his kidney function. So I guess the next poll is up.
So the poll, number 2, what would you do now? Would you repeat the kidney biopsy? Would you just treat him conservatively? Or would you get genetic testing?
Well, he's already on ACE and ARBs, right?
He has not been taking it.
Oh.
So he's been off.
But it was prescribed.
It was prescribed, but he has not, in being honest, he said he hasn't taken it in 2 years.
I mean, it's a good point, because let's say he was on it and his proteinuria was 1 gram. It may influence your thoughts about this, but maybe not. A little more time here.
Did he? You may have shown this. Did he still have a lot of microscopic hematuria?
He did a little less, 30 RBCs now.
Still.
Yeah. All right, we'll end it right there.
So we've got 2/3 want to do genetic testing, about a fourth would like to repeat the kidney biopsy, and some are saying it's over, it doesn't matter, let's treat him conservatively. I think they're all interesting possibilities, and I'll hand it back to Dr. Baxi.
So yeah, I think based, and this is what I did, he, on further additional information, which after the labs came back, I kept on asking him more questions, and sure enough, he says, his brother and sister have recently been told of blood in the urine. And so that definitely piqued my interest, and he doesn't know if they've been given a diagnosis, but again, he says he's had no hearing or vision issues. He had these tested with his pediatrician over the years. So what I opted to do, even though that was a significant renal function decline, was to first do genetic testing. And sure enough, with this is what came back. So he did have, believe it or not, a mutation in the alpha 5 subunit of collagen. So this is X-linked. So he has Alport's. He has X-linked Alport syndrome. And I think that was really the final diagnosis. And with that, I chose not to pursue further kidney biopsy testing. And I think, as always, the audience kind of picked up on this quite quickly. But this was kind of a little of a more expected from my end after he told me the family history, but this is still a pretty interesting course. So
Dr. Rubin gets the gold star today.
Yeah. So
come on, Mario, you got to smile.
So
just thinking, and I'm sure Pravir will get into it as far as, and it was mentioned in the chat, the association between collagenopathy and FSGS.
Absolutely. Yeah, this audience sometimes steals my thunder.
Yeah.
Yeah, so everyone
Sorry.
had it. So I had to stay quiet because everyone was getting it right. So just a really background on the genetics. And again, I have to review this like 3 times. We had a case recently, and I probably will have to review this again. But just in general, again, when we think about Alport syndrome genetics, there's autosomal, which is not the most common part, inheritance, but there are, and those are chromosome 2 with a collagen, the A3 subunit and A sub 4, the 4 alpha 4, which are in these genes. And autosomal recessive Alport syndrome accounts for about 10 to 15% of all cases. Autosomal dominant Alport system is considered to be quite rare, but we'll get into some of those changes there. X-linked, of course, is what this patient had, and in general is about still very rare, 1 in 2,000 in the population. And the biggest part of this, as this case was, that is the features can vary. Not typically an X-linked, but a lot of these autosomal ones, they can have just isolated hematuria, to kidney failure, hearing loss, and a lot of people picked up on, the vision issues, the fleck retinopathy that can get lenticonus, they can get as well. Because this type 4 collagen and alpha subunit is in the eyes and the ears. So recently there was this new classification system that was put out, and it's really the focus of this is to really highlight the genotypic or genotypes of these patients rather than the phenotypes, because again of the variable presentations of each patient. So of course the X-link we all know of, and male subjects will have 100% risk of ESRD, where the women, because of the mosaic pattern and random X-linked activation, can have kind of a variable course. However, the 2 things that have changed here is this inclusion of what we used to call thin basement membrane disease, or benign familial hematuria, into autosomal dominant Alports. And so really the term thin basement membrane disease has kind of fallen out of favor, and these are grouped into autosomal dominant Alports. The other big category that I still have to sometimes put my head around is this digenic Alports. Basically, in this category, you have patients who have you have 2 mutations. They can be either a collagen alpha 5 subunit, which is on the X chromosome, along with either a 3 or a 4, or they can have a 3 or 4 on the same chromosome or on opposite chromosomes, which would be your trans, opposite, and cis on the same. And in trans, these usually present quite commonly as your autosomal recessive, because they have 2 mutations and they're just different. So that's why they're designated as digenic versus Alport's recessive. Whereas your cis mutations usually have a variable presentation, again, up to 20% can have ESRD, and it kind of follows more of the 20% that you see in autosomal dominant. So again, this is kind of the focus here is on genotype rather than the variable phenotype. Go ahead, sorry.
So cis means you have 2 mutations from one parent.
Right.
Yes.
And you have one other chromosome. You have your other chromosome, which is fine.
Fine, normal. So
that's why it's so minor. Okay. And trans means one chromosome from each parent has an abnormality, and that's why it adds up to be 100%. You have no normal.
Yeah, and the only reason it's different is because recessive is classically, 2 mutations in A3 or 2 mutations in A4, where digenic just means that there's 2 different mutations. There's a 3 and a 4, and sometimes these digenic mutations don't follow classic Mendelian genetics. That's why they divided these into these 3 different categories.
And isn't this digenic? Some people also call what double heterozygote or mixed
heterozygote.
Double heterozygote.
Yeah,
that may be a better term because it's so hard to put this together. I struggle with it a lot.
I always like they call it a compound heterozygote. Maybe double's the same thing, but
yeah.
The last one there is the interesting one too, because I don't know if this is from that one review, but I remember the review I think I showed you where they actually have it in a pictorial, which is really kind of nice to try and figure it out. But you can have these alpha, the alpha 3, alpha 4 abnormalities and coexisting with that alpha 5, which kind of like trumps everything. And those people have a terrible prognosis.
Yep.
That's the bottom. That's the
Yep,
very
Yep,
bottom.
that's
there.
excellent. Yeah, the alpha 5 is really the,
That Trump, I mean,
excellent.
no surprise, but
Yeah.
it trumps everything.
But it's
Yeah.
interesting, I want to call it Alports Plus, but we can't use the term Alports anymore. You know what I mean? It's like
Yeah.
X-Link. It's like X-Link Plus.
Yeah.
So I
X-Link
suspect Steve, they get renal failure even earlier than the typical.
Right? No, they have exactly, much more severe prognosis.
Really interesting.
The obvious question right now is, I don't mean to be preemptive, but maybe we're going to get to. All right, David, did somebody finally then ask you to do the alpha 5 chain?
No, well, here we are. So why is it important? Why did they make this change? Again, it's the variable phenotypic presentation of these patients. And so focusing on the genetics with our more readily available genetic testing can allow for the earlier diagnosis. And we know that RAS inhibition is part of it. And when I was reviewing this, a lot of it actually comes for humans is from retrospective data, while the experimental studies are really more in animals. But there is data that, it delays kidney failure by almost sometimes 1 to 2 decades in patients who have X-linked Alports and autosomal recessive Alports, which is a big deal. And they've gone so far in the pediatric literature to say that, for patients who have X-linked Alports or autosomal recessive Alports, they should all be started on an ACE or an ARB at the time of diagnosis, even if they don't have proteinuria, which is, again, this is the guideline, this is the recommendation.
That comes from the registry.
Yeah. And versus those who are women, again, because of the mosaic pattern of their mutation, or those who have autosomal dominant, they're typically recommended to start an ACE or an ARB at the onset of albuminuria when they have proteinuria. But that's why this is pushed so much in terms of changing the nomenclature, not saying thin basement membrane, and really focusing on Alports. The other point, of course, is clinical trials, which we've talked about a lot during this conference. And, knowing this, even though there's no treatment today, as of now, hopefully there will be. And, there was a recent drug, unfortunately, that did not pan out for Alports. I can't pronounce it, bardoxolone. It's been used it's been studied in other
Is that the
GNs
one
as
in
well.
diabetes as well?
Yep, and
Yeah.
in Alports, what basically did is it actually increased EGFR and increased proteinuria, and it was probably increasing glomerular pressure. So it was actually it's all those future studies with that drug in this GN have stopped, but there's other things going on, and some of these we may kind of recognize with other GNs, sparsentan, finerenone. Some people mentioned that in the chat. So maybe there will be something more than we have than RAS inhibition, but again, this is why it's important.
Drugs looking for a disease.
Yep.
No, but what you bring up is extremely important. And if you look up the European Alports registry, they have really nice data in there where they show that if you give ACEs and ARBs early, which is as you suggest, when there's no proteinuria or proteinuria less than 500 milligrams, their course is significantly different than matched controls who basically, or even siblings who don't get treated and go on and progress much more rapidly. So it is interesting how just that alone can make a big difference.
Yeah. And then coming to, again, the audience was on top of this, FSGS pattern of injury and Alports. There is a link there. And you've already heard this in the chat, but we used to think we knew there was this coexistence of FSGS and the biopsy in patients who had Alports. And it was thought that, these are secondary changes as a result of the collagen defect in the glomerular basement membranes, inducing, the segmental scars. But we found that a lot of these patients, and these are just 2 examples of studies, one that was mentioned in the chat in the Chinese population, where they found that 12.5% in this paper, at least, they did genetic testing in patients who had so-called familial FSGS, and they found collagen alpha 3 subunit mutations in 12.5% of them. Similarly, in this study in KI, they found, 10% of families who were diagnosed with hereditary FSGS, again, had a mutation in either collagen, the alpha 4 subunit or the alpha 3 subunit. So again, this FSGS link is thought to be part of this type 4 collagen defect. And so this is just another bigger study or another large study that you'll see quoted again with this link. And what it showed here was that these collagen, type 4 collagen mutations are really the most frequent mutations underlying some of these patients who have adult focal segmental glomerulosclerosis. And here what they did is they looked at, again, families who had familial FSGS, And 24 of these families had a history of renal disease. They formed their own targeted gene panel of 39 genes, which included some of the hereditary known causes, you know, the potosin of FSGS, but they also included all the type 4 collagen genes. And they found that, again, the mutations in the type 4 collagen, specifically 5, accounted for the majority of mutational abnormalities in these patients. So there is a link. And so when you do see this FSGS, you know, you should be looking for genetic testing.
Well, which means in these people, unlike the other people we talk about, this is a glomerular basement membrane abnormality, not a podocyte issue.
Mm-hmm. Yeah.
This is really interesting because it really stresses that, you know, not to be, say it for the 40th time, but you know, that FSGS is a pattern of injury and you have to look for the underlying pathophysiology. And I didn't realize that could be that high in adults. You wonder how many people got missed, you know?
Yeah.
Because of all the different phenotypes, they may not have hearing loss. It may happen later in life, but they've got some alpha gene collagen 4 alpha abnormality. That's really, really interesting.
The other thing to keep in mind, which I stuck into the chat, is had this child been biopsied back when he was 6 years old, he may have only had thin basement membrane nephropathy and had that diagnosis, because that's how it first presents, to be honest. And I actually had a lady that Priya and I reported years ago, a woman who had a biopsy at the age of 13. It was thin basement membrane, and then 15 years later had Alports. It's kind of the evolution. It's too bad, you know, the EMs would have hopefully made the diagnosis for you. You would have seen the basket weaving and all the other basement membrane abnormalities. Maybe not, but that's what you would have been looking for
or
sure.
just genetic testing, right? Again,
well, now you have that, right? We didn't have that.
And that, yeah, exactly. And that's what's really changed is, yeah, maybe 10 years ago we had a lot of these, but genetic testing wasn't as easy as it is nowadays. And so this is just from that same paper, and this was interesting because, again, very similar to what, you know, our patient had. A lot of these patients, again, had someone called familial FSGS, and if you look at the EM, some of them had no diagnostic material. Going what Steve said, some of them had, the first EM was normal. This patient was biopsied again and then had that classic GM, glomerular basement membrane lamination that you see in Alports. And one of them, they actually retrospectively went back and looked for changes. And one actually had a normal EM. So again, this is not, so what has come recently, this is in 2022. Go ahead.
I want to, yeah, getting along, you know, what's kind of what Steve was saying. So let's say this patient was biopsied today and we saw he was 7 or 8 or whatever, how old he was, and we saw thin basement membrane, and we don't know at that point, is it just what it is? Two things you could do, right, to determine. In the old days, we just call it thin basement membrane, but maybe all these patients, not maybe, I'm sure Steve's going to argue 100%, you should do Cal 345 IF on, right, Steve?
Yeah, but you should do the genetic testing.
And genetic testing.
More
and then, you know, because we might have thought this guy only had, I'm sorry, Steve, we might have thought he only had, you know, what we used to call thin basement membrane disease, when in fact he has A5, alpha 5 lesion, which is a very different prognosis. And even with or without that family history. So
well, that's the other thing, right? I mean, to Praveer's credit, I mean, he got the genetic testing, but part of what's spurred it on was the family history, and kind of what you're getting at now, Praveer, is even without that, we should be looking at this stuff, you know, checking these people, especially when he was at 6. You know, some 6-year-old comes in with that kind of hematuria and no proteinuria. You get a biopsy, and for sure, if you find thin basement membrane, I think you're obligated to get the genetic testing now, just to be sure. I mean, it used to be a real chore. Now it's just so simple, it's not even funny.
I could say a 6-year-old comes with hematuria and you do genetic testing and you don't need a biopsy.
Well, that may be true too.
And the other question, going back to the immunofluorescence for the collagen, type 4 collagen, if they have a 3 or a 4 collagen defect, I mean, the immunofluorescence still may be normal. It depends. So some of those will not have, you will not be able to diagnose it even just on IF. If they had a call 3 and call 4 and they didn't have the collagen alpha 5 subunit. So the IF again has a lot of flaws and limitations.
Yeah, but can't David stain for all 3 of them?
Yeah, but if you have a type 3, if you just have let's say you only have one gene mutation in collagen subunit of alpha 3, and again, David, stop me if I'm wrong. The 4 is normal, and they're made up of 3, 4, 5 trimers, right? So it can still be normal appearing, and that does not rule out or rule in, sorry, it does not rule out Alports, right, David?
Yeah, I agree with you, Prabir.
5's the big one. I mean, that's the one, it stains Bowman's capsule, stains the capillary walls and the distal tubule. And I'm still sitting here on like pins and needles. Did we ever do the alpha 5?
Yeah, so no, we haven't. Just this is just a relatively recent case, and again, it'd be interesting to go back and see. It won't change anything now. We have a diagnosis, but the last thing I'll put in here is this from 2022 to 2022, just a couple years ago. See, Jason, they came out with genetic kind of guidelines for genetic testing and management Alports, and it's interesting. Forgot to highlight this, but there's a couple things. Of course, when you have biopsy-proven FSGS and you have a patient who is either steroid resistant or has a family history, those patients, you should get genetic testing. And I think we have been doing that more recently because of the availability. And then finally, it is this familial IgA, which I didn't go into in this session, but there's a whole subgroup, just like FSGS on biopsy. There's a familial IgA, these patients who have families, they've been diagnosed with IgA, but IgA along with a collagen, type 4 collagen defect can also show up. And so, that's another subgroup of patients that we should consider genetic testing for type 4 collagen.
Yeah, I mean, Bill Wyatt years and years and years ago, reported, and I'm talking a long time ago, reported about in pediatric populations, there were really this familial IgA nephropathy, which we hardly ever talk about. And I don't know if anybody's published anything more about it in a while, but I just remember that, I don't even know why I remember his name, but I just remember he had a few articles out there where he had families that had IgA nephropathy.
Dr. Radby, I think once you think of Alport syndrome and even absence of eye symptoms and hearing defects, I think we should ask for hearing testing and ophthalmological evaluation clinically. You will be very surprised how many times it comes positive.
I'm sure you're right, and I saw your note in the chat because I wanted to follow that up, and just to play devil's advocate, I mean, if you start with genetic testing and you made a diagnosis, do you really matter to have any of that other stuff? Is there anything we can do about eyes or hearing?
I don't disagree with that, but I'm just saying that during the clinical calls, where like in Canada, it is not that easy to get genetic testing. I can get it quite frequently. It's run through my office, but I can tell you it's not that easy. And so these little things do help clinically.
Supporting, absolutely, good point.
It is interesting that because I've had a couple of Alports. I actually, Cliff Cashton, who's kind of one of the gurus of Alports from Minnesota, a couple of his patients have come down here and I followed them. And the minute they walk in the clinic, you can almost tell they've got hearing aids in already, and they're only 22 years old. It is interesting. This gentleman has no hearing abnormalities whatsoever, right?
Not that we know of.
I mean, it's usually low tone, it usually starts, I think, as low tone hearing loss. The other part of it, the anterior linea conus and the macular flex and stuff, first of all, try to find an ophthalmoscope. And then secondly, it's not that easy to look in somebody's eyes. And I used to try a lot. You need a slit lamp exam to really, pull that off. Theoretically, with the anterior linea conus, you should be able to see it if you look at them, look at the eye laterally. But, it's not that, I'm sure it's not that easy. But yeah, I mean, the one good thing I think about at least having hearing audiometry is that you might pick this up early and they can be monitored so that they can get, hearing aids or whatever assistance they need, preemptively. I don't know that much about the ophthalmologics causing problems. I mean, with the macular flex, they may have blind spots or something. And I don't know that the anterior linea conus causes any real problem per se. Somebody else may, but I'm not aware of it.
The other thing I wanted to add, which again, I learned this morning from this lady named Judy Savage, by the way, from Australia, is that OCTs can show you thinning of the optic nerve, which is another marker of a type 4 collagenopathy. In addition, recently there is a cystic form of Alport's, which has been described. Multiple cysts, it resembles polycystic kidney disease, but the difference is that the size of the kidney is normal to small. But that's another thing. And lastly, there is data on the use of SGLT2 inhibitors in Alport's, which most likely, according to her statement, will be a way of practicing a year from now. So that's
So
all I want.
are the cysts throughout the kidney or just in the cortex?
No, throughout the kidneys.
Are they?
Yeah, there's definitely a link with cysts, and then there is ongoing studies with SGLT2 inhibitors in this, along with all those other clinical trials.
Now, Pravir, am I dreaming or you presented a digenic Alport a year ago or so?
I did. And believe it or not, these two cases came within a couple weeks of each other. So go figure. And I have another one I'll save for later, which goes along. Hopefully you don't remember.
Oh, now you've already set the stage.
Familial
He's
IgA.
looking for it.
We'll have to wait a year.
But the point that Dr. Rin made is right on. I mean, this lady also pointed out that this deafness can be subclinical. So you need to do hearing testing.
I mean, it's amazing. You think what genetic testing has just, 5 years ago, 3 years ago, it was a pipe dream, or it was a send somewhere, or they couldn't afford it. And now, at least in America, it's pretty readily available. We get a really good panel. And, anybody with any cystic disease now, any unexplained interstitial disease.
Anything.
Steve had the H whatever one is also has
Hepatocyte nuclear factor beta 1.
Yeah, that's autosomal dominant, but it has a lot of cysts. And so anybody that doesn't fit the pattern maybe anybody with cystic disease and renal failure anymore, unless it's quite obvious that they got ADPKD. It's really amazing. And here's another really, really good example.
I mean, you get over 350 genes. It doesn't cost any more than $300. And for most of these people, out of pocket, it's almost nothing, or $50. And I think back when Athena was doing Podicin, you'd have to spend almost $1,200 just to get the Podicin analysis. So, I mean, I understand it may not be the same in Canada, but here it's unbelievable how easy it is to do this. And as we see, it's like you throw it up there and you see what falls out. I mean, sometimes you never know. And we kind of fall across, you trip across these things, and you're glad you did.
We are working here in Canada to get these genetic studies. I'm lucky that I can get it quite readily through my own clinic. I have a collaboration with American company, so I'm able to get it.
Yeah, it's too bad. Is Natera not up there in Canada, or is
not
just...
yet? No.
What needs to be emphasized is not just the question of ordering the genetic testing. There is so much that comes into it, genetic counselors, discussions with family, and so forth. So ideally, you need to have that sort of nucleus of people that are working on it to refer cases to them.
Well, Natera has genetic counselors that work with them, but you're right. At Rush, we're lucky. I had one lady has a mosaic Turner's, which is not what I was looking for, and that's what she ended up having. And she has children and everything else. She didn't have a web neck, but I'm sitting there thinking, I wasn't looking for this. Now what the hell do I do with it? I talked to her for a while. I gave her the option of calling a geneticist at Natera, and then I sent her to one of the genetic people at Rush. But you are exactly right, because there are a lot of questions that start popping up with this that many of us, and especially me, are not really equipped to answer. Great case.
Yeah, that's wonderful. Anybody have any other parting comments? Any other pearls, Mario, from this morning? I mean, you kind of try and upstage us with all your information.
No, just bring the cake next week. We look forward.
Okay.
Savage sounds, that name is really familiar, Mario. Is she an older person? Yeah, that name is very familiar, and I don't know why.
All right, I'm going to wrap this up. Thanks, everybody. We'll be back next week. Remember, hopefully Dr. Glassick will be here. I'll prompt you somehow. I'll just say I'll put a cake up and I'll just make everybody sing. So it'll be a lot of fun. Till then, everybody stay safe.